Hallo, hallo, folkens. Er det meg du klapper for, Knut? Så kjekt. Ja, pausen er over nå. Så da er det tid for å finne plassen sin igjen. Og tid til siste foredragsholder. Så da vil jeg ønske velkommen til dr. Jonathan Verderam fra Vital Chiropractic i Arendal. Han gikk akkurat ut. Nei. Er det det som heter perfekt timing? Men nå kommer han inn igjen. Ta vel imot Jonathan Verderam.
Thank you. Some of you may not have to do this, but for a moment, just imagine waking up in constant pain, perhaps dizziness, pressure in the head, problems focusing, brain fog. You've gone to every test, you've gone to every specialist, and everything comes back and says that it's normal. Then comes the thought that breaks many people. It must just be in my head. There's nothing there, it must just be in my head. I've heard this sentence one too many times. And some of my patients are even prescribed antidepressants, not because they're depressed or maybe get depressed after a while, but because no one can find the underlying cause to their problems. I want you to understand that there's a big difference between normal, average, and optimal. You see, what we do oftentimes in medicine is take the average and say that if you're in for referanza, everything's okay. Take blood pressure, for example. Somebody that's maybe a bit taller and somebody that's a little bit lower has different blood pressure, and they should. Take the average in the middle, and that's not optimal for anybody. Average, normal, optimal, very different questions, and then we get very different answers. My name's Dr. Jonathan Verderam. I'm a chiropractor from America. I've been in Norway for over a decade. I've been seeing these types of patients. And my goal for you today is to start to think differently, to ask different questions, and then we'll get different answers. As Aristotle said, to avoid criticism, do nothing, say nothing, and be nothing. I've got to hand it to these two docs earlier today. They did fantastic. They have the guts to stand up against the establishment, so to speak, I don't know what you want to call it, and do something different, and I applaud that. I just want to get this out of the way really, really quickly, that I'm not here to diagnose or treat or cure anybody of anything. That's not my goal. My goal today is to help you understand how the alignment, gravity, and the structure affects the function. For those of you that know me, you know that I'm quite a nerd and I love the research. We're going to talk some research. We're going to show some pictures. Some of what you see today is going to be quite remarkable. So buckle up, as we say in America. Probably because I'm American, I try to speak out and say something a bit differently. Let me introduce you to one of our patients, Børge. Børge is born with cerebral palsy. And when he came to me, just completely stiff-bored, tingling in the feet, difficult standing, difficult working, and difficult doing what he wants to do. Gone to every specialist. Everybody told him everything's, we can't do anything for you. This is it. Learn to live with it. Maybe that's another one many people have heard. Learn to live with it. After Atlas orthogonal care, he stood up right for the first time differently. Something was different for him. You can see the look on his face, says it all. Börjar aldrig klart att stå med rätt i kroppen. Of course, what came after this was some criticism, not from the medical doctors, but from the Chiropractic Association. I think many people are often quite shocked when they hear that people are coming from all over Norway, also out of the country, to come down to little Arendal. Come to me, not for my good looks, that's for sure. I think what surprises, some of them are even coming from Denmark and Finland and Sweden. People like Børge, for example, coming far. But I think what surprises most people is when they see this list here. These are the potential things that we see with cervical medullary syndrome. Arrhythmias in the heart, numbness, weakness, vertigo, dizziness. Symptoms that don't really make sense, that don't really add up. But when we assess the upper neck and look a little bit differently, we get different answers. If this looks overwhelming, that's the point. This is all the potential pathways that we've found when you have damage in the upper neck and the potential causes and what can happen, and why we have so many different types of complex cases coming in with the same underlying cause. People like, for example, that have maybe torsion on the brainstem, and then affecting the spinal trigeminal nucleus, affecting their face, migraines, ear pain. Or perhaps the POTS patients, postural orthostatic tachycardia syndrome. Or maybe, and we're going to go through some of these, I mean, each one of these I could sit and literally talk for an hour on, so I'm going to try to go as fast as I can. I've timed it, so I know I've got 45 minutes here. And one of the most fascinating is the cerebral spinal fluid, which we will get to. But how do the problems start? I want to just say that this is not based on just some theory. This is research that I published earlier this year outlining these different mechanisms. So again, I'm super nerdy. This doesn't make sense to anybody probably. But it's not theory. But why do these things start and how do they start? I'm going to go through 3 of the most common types of injuries and probably 3 of the most underlooked. This is a car crash at 12 kilometers an hour. Now watch the head and watch how much movement 12 kilometers an hour is. 12 kilometers, this is like rolling through the parking lot, just rolling through the parking lot, that's it. And I think so many people come to me, they're like, yeah, no, never had any injuries. Maybe a small fender bender, kind of hit from behind, but no, there's nothing. Just take a second and watch what happens here, slow motion here. Look how much movement and sheer forces we have at 12 kilometers an hour. I think the problem is twofold. The one problem is that many times we don't think anything of it, right? Which makes it hard for the insurance companies to say, oh, I had this accident and then I have this problem. That's what they want. They want you to go right into the FOSTA and tell them all the symptoms you have, everything that happened right after this. It just doesn't happen like that. And the research backs this up. 2019, they found that on average, after a mild car accident, on average, it took 11 years for the degeneration and problems to come about. So if you're lucky in a way, you get symptoms right away and maybe you can make the connection there, but for most people, it doesn't happen like that. So these micro traumas aren't so micro after all. This is the mechanism of injury. This is what happens. You get hit from behind. The torso goes forward. The head stays in the same place. You go into rapid extension and flexion, and it's that sheer forces that's enough to create damage on the ligaments, which I'll show you in a minute. A lot of the times, the muscles don't even have time to react, and that's kind of the biggest problem of it. The next micro trauma, so we have 2 types of traumas. We have a macro trauma, which I guess a car accident is more macro. We also have a micro trauma, and it's the thing that's inside of all of your pockets. How many, not you guys, of course, sorry, not you guys, not here, but how many times do you see this? Holy smokes, the last 10 years, I cannot tell you how many kids, younger and younger, with spänningshodepinned, concentration problems, all day long. The research shows that 3 centimeters, so look at me, 3 centimeters forward, what does that mean? The research shows that it adds 5 kilos of force onto the neck. Typically, what I'll do is I'll measure the acoustic meatus in the shoulder, the glenohumeral joint. You can see how much translation we have forward. 3 centimeters, 6 centimeters, we're talking kilos, 10, 15 kilos. And this is the hard part here, right? That it's not just the one ice cream that made the hole in the tooth. These things build up over time. On average, does anybody know how long we are on the phone every year? 1,500 hours on average down here. Gravity pushing down. I'm just going to warn you about the next one. So we have whiplash, we have micro traumas with the telephone and work situation. The third one, this is graphic, just to warn you, for the men mainly, the mothers not so much. Normal birth. Normal birth, cesarean. The doctor grabs the head, gets the baby out, doesn't allow the mother to do naturally as they should. Research from Germany showed that 80%, it was Dr. Gutmann that found that 80% of the kids that he studied had damage in the neck from a normal birth. So often from day one, we begin to have problems. And then we grow up and live our life like that. If you see that I get passionate about this, it is the case. To understand why these traumas can have such long-term effects on different people, we have to first understand a little bit of anatomy. So stay with me. I know this is going to get dense here for a second, but I warned you I was a bit of a nerd, so let's get into it here. We're looking at the alar ligaments and transverse ligaments. We're mainly concerned with these two because Panjabi in 1998 found that only about 3%, 2 to 3%, was enough shear forces to create permanent damage on the ligaments. This will make more sense in a second, but the point is that it is very delicate. I think this is something I really like to do. I'm going to need your help for a second. To understand how sårbar, how weak, and how vulnerable the system is, we need to understand how, ooh, she says.
This is heavy.
Does anybody know how heavy the head is? On average, 5 kilos. So this is actually less. If you want to come up and feel afterwards, come and feel it. On average, the head weighs 5 kilos, and that's where this comes in, right? 5 kilos, and that's how it builds up. Does anybody know what this is?
First.
Good job, doctor. You got it.
First vertebrae.
What does that feel like?
Very light.
On average, 56 grams and 5 kilos. Oh my goodness.
Holding all of that.
You got it, sister. I told you you're going to come up and speak for me. You thought I was joking. 2 to 3%, that's all it takes. The biggest challenge with this is that these ligaments are not easy to see on standard imaging. The radiologists aren't doing the measurements that are internationally required to do. And you can't see them when you're laying flat without movement, how the ligaments interact with gravity. Here we're looking at the atlas bone that we just showed you here. We're looking down this way. These green ones are the alar ligaments. The transverse ligament is the other one. They kind of act like seat belts, stopping the head and the atlas from translating too far. This is a cadaver, so this is looking straight at the alar ligaments, and you can see how thick and beautiful this looks, nice and healthy actually. But I want you to see that it's not like a mechanical machine. These structures and the way that the upper neck, the craniocervical junction is formed is that it is very vulnerable. And the vicinity, how close it is to the brainstem in some of these structures, is very close. And this is why when these ligaments stretch just a few percent, it's enough to shift and create issues. Here we're looking at the upper part of the neck here. If you just split the head into two, we're looking at the atlas and the axis. This line, the BO line, is something that the radiologist should always at least do and take a look and see if the cerebellar tonsils, the back hindbrain, is involved. This is normal, and when it measures, it should be 2 millimeters above this line. Then you have enough room for the cerebral spinal fluid to come in and out of the head. What happens is that when the upper neck becomes unstable, when the ligaments become laxed, you start to get cerebellar tonsillar ectopia, Chiari malformation. And that measures 3 to 5 millimeters below this line, okay? The research shows that this is not congenital, that it can happen from a whiplash injury. And these names maybe look a little bit familiar. At least Centeno, you brought him up earlier. And my colleague Scott Rosa, shout out to Scott Rosa for some of these images and the work that he's doing in New York. Absolutely incredible, what you're going to see later. This is not because of just genetics and bad luck. These things happen. There's causes and effect. I think the ones that concern me the most, I'll just go back for a second. So we have 2 millimeters above the line. We have 3 to 5 millimeters below the line. But what about the ones in between? These are the difficult and most difficult ones, the undiagnosed ones, the ones where the MRI says everything's normal. And clearly the line hasn't been drawn, and you can see that it's tight, that it's affecting the spinal vesca and causing head pressure, brain fog, autonomic changes. So it comes after a whiplash. Also, the good news is things can be done. So this was research published again by Scott Rosa and the founder of Atlas Orthogonal Technique, Roy Sweat, 54 patients, 84% of the people with whiplash injuries improved with the hindbrain herniation. So the good news is things can change. I want you to understand that not all injuries are the same. This is how we classify the different types of ligamentous injuries. We have a grade 1, which is just partial. These are the ones that will definitely not show up on imaging, but it's affecting it's enough damage to affect the way that you feel. We have the next one, which is grade 2, 2/3 of the membrane. These are the ones that, for example, have persistent neurological symptoms that won't resolve. They just keep coming back, pull. And then grade 3, which is like, at this point, it's chronic. But this is the point, that not all injuries are the same. It's not normal or abnormal. There's a spectrum, and it's the gray zone, the gray spectrum, where most of the people are. And sometimes the difference between just fine and disabled is just that partial tear. I want you to please understand how complex this joint is, and how neurologically complex, but also how biomechanically vulnerable this area is. These are all the potential damages from all the other ligaments in the upper neck, especially the grade 1s or 2s. You're not going to really see these on standard imaging. You're going to have to take an upright MRI, dynamic imaging. And when you see these things in motion, it starts to make sense. This is a patient with EDS, a Bindeweefsziekte, hypermobility. Does anybody know what that is? Most of the doctors don't. And the report says everything looks great. No pathology detected. This image we took in our practice, we're looking at lateral bending to the right and to the left, open mouth. This is not DMX. This is standard plain film radiography. Under motion, we can do this everywhere. Why don't they do it? I don't know. I think it's interesting. You really set the stage. A lot of that I didn't understand the background in Norway. But you see that when we bend the head, not everything isn't so fine. We're looking at 5 millimeters of translation. So the atlas going here should be 0. There should be no motion going this way. 65% of the rotation comes from these upper joint complex, C1, C2 specifically. So that when we go for the side, the alar ligament should hold it in place. When it slides down, that means that one of these are involved. I can't see the ligaments for sure. This is why we need upright MRI. But I can tell you with certainty that there is a moderate to high degree of instability here. I want you to think about what happens throughout the day. Now, this is very severe, but imagine the mild ones. What happens every day when we're moving our head if the ligaments aren't holding everything in place? Does that make sense? Does everybody see that picture there? Because I think I did have a laser, yes. So we're looking at the side here. This should be 0. 4 millimeters to the other way. This should be the new mantra. You can't find what you don't look for, right? This, again, is looking at the upper neck right up here from the side. We're looking at the part of the occiput here. This is the dens. This is the front part of the atlas. This is the brainstem. Tough to see, but I'm going to train you guys now to be a better radiologist than many. We're looking at the tectoral membrane. So we're looking at this structure right here. Do you see the difference, how thin that is? This stuff is subtle, but the consequences are absolutely not. That's not the only thing. We also see that there's some brainstem compression here, potential ventral brainstem compression, that we have a bit of a pannus pushing back into the brainstem. So I want to just, again, make a caveat here. I've got friends that are radiologists, and I have much respect for them. But they're trained and they're expected to prioritize the life-threatening, and they should, right? Fractures, tumors, bleeding. If those aren't present, then often it will just be a normal MRI, no pathology detected. But no pathology detected does not mean, again, optimal function, right? This is the gray zone that we're talking about. So while these findings, like this, for example, are definitely not life-threatening, they are absolutely, if you're one of these people, you understand that these are absolutely life-altering. Okay, radiologists, let's get going here again. We're looking at the upper neck. We're looking down this way. we're looking at the atlas. This is just the front part of the atlas here. The spinal cord, the white is the spinal vesca. That round is the dens, so that's number 2. Does anybody follow me on this one? We're looking down this way. Can anybody see what's wrong with this? Again, supposedly normal. This is laying down, although this is taken in Norway. Supposedly normal MRI. Anybody see the difference? Come on, doctors. Look at the periodontoid space there.
It's not the same on both sides.
Exactly. When we see such a big asymmetry, we know for certain that the alar ligaments are on some degree involved. May not be completely tore, but absolutely these stabilizing ligaments are in trouble. You also see this here, which is that ventral compression that we're talking about. Look at the space here. This should be much wider. The white is the spinal vesca. And then the other thing too, we can see that there's just torsion, that everything's getting pulled down this way. Do you guys see that? God, you guys are good. I knew it. He said it. He's like, you're going to come here. They're smart. So this is a diagram of what we're looking at, the atlas, the spinal cord. And to understand how the geometry, how the structure, how the bones affect the neurology, we need to understand these 2 ligaments right here on the side, the dentate ligaments. This is a direct connection from the spinal column directly onto the dura, which is what's holding the spinal cord into place. And then what happens when we get the torsion, this is called the dentate ligament theory hypothesis. When we have the rotation, then we start to get the torsion. And when we get the torsion, we start to get issues with these tracts. So inside of the spinal nerves, we actually have different tracks going from the brain down to the body. Specifically up at the brainstem, the dentate ligament, when it pulls, it's going to affect some of these roads, some of these pathways. So for example, pulling, affecting, let's say, for example, the spinocerebellar tract, and then we get dizziness. Or probably the trigeminal nucleus, and then we're going to get facial pain. The findings are subtle, but the consequences are not. This is that same patient looking from the side, and this was the area that we were looking at right here, this upper part. And you can see how thin that is right there, right? It should be much thicker. No hindbrain herniation, but maybe a little bit low. If you draw the line from there to there, it's pretty low. This isn't theory. This is cadavers. You can see that the dentate ligament is connected. Again, not my theory. We're just showing you what the research shows. Another great example of things that go unmissed. I promised you I was going to train you to be a radiologist. Is this cool? So we're looking at front first, in the middle, looking straight on, cut into 2. So cut right about here, looking at the jugular veins on the right. So this is the right and this is the left. Look at the space here and the space here. Can you guys see which one is bigger?
One to the right.
Yes, that's bigger, which is the patient's left. Yeah, exactly. This right here is looking, if you just cut right here, looking this way, can you see the difference between the right and the left? Again, normal. This is normal. No pathology detected. Nothing to say about this patient's dizziness and brain fog. For sure it's going to get worse up, right?
Because this was taken, well,
In Norway. This is Norwegian MR Kaput.
and that was laying down.
Laying down. You can still see some of these things. But again, you got to know what you're looking for. You need to do the measurements. Thank you, sister. I was like, why don't you come up here? Earlier this year, NRK did a story on Camilla. Camilla, like so many others, had traveled to England after her MRI was said to be normal. Everything normal, goes to get her weight-bearing MRIs, and it told a different story. She went and had atlas orthogonal corrections. This is long before I came to Norway. And NRK asked me to comment on this, what my thoughts were, and I said, like many other here, that upright MRI shows a different story. It's looking at something different. And I said, when is enough research going to be enough? It sparked national debate. There was a neurologist that was really critical, and you can read like all the stuff down below in the article if you want to. And his objection was that there isn't enough research. So I decided, and it's a valid concern. So I decided to answer this, not with my opinion, but with research. And so we had this published in the European Journal of Radiology, which is like Q2 high, like for, again, the nerds, it's a high index journal. This is important. And what we concluded is, unequivocally, we're looking at different things. We're finding things that aren't found on laying MRIs, static MRIs. We're looking at something different, right? I also concluded, this is extremely valuable, it's in the article too, that people like me, the upper cervical chiropractors, this is very valuable for us when it comes to the prognosis, what we can do. Maybe we need a referral to stem cell in Centeno, for example, that many of my colleagues do. Ultimately, posture matters, gravity matters, alignment matters. So let's just real quickly go through some of these concerns and settle it for once and for all. The evidence has grown since the last time when you guys were so, put the fight on. The evidence has grown for sure. And the argument is so often that, oh, the quality isn't as good. The quality's worse. But again, we're looking for something different, right? This is like comparing ultrasound and X-ray. Like, I don't really care if the quality's that good, because most of the people have already taken a normal MRI and everything's fine. So for just pathology, I get that. But again, we're looking at something different. The other, this is a great study, systematic review in 2025. I mean, it's about as conclusive as you can get. The other argument is that there's not enough randomized controlled trials. And for those of you that aren't as nerdy as me, RCT is kind of the highest kind of research you can do. Again, valid, but it's kind of a wrong argument if you think about it. Because most of what they do at the hospital doesn't have randomized controlled trials. Only 10 to 15% of what they're doing is based on randomized controlled trials. So if we wait for the randomized controlled trials, it's going to be too late. People are going to suffer. We need to see what's going on. We can rely on other things. We can rely on clinical reasoning, logic. We can look at the neuroanatomy like we're doing now, the biomechanics. The limits of our tools define the limits of our findings. When we limit our tools, we're going to limit the findings. And what normal MRI does, it's kind of like a keyhole. Like we're just looking through the keyhole. We can see bits. Yep. And what the functional testing are doing, it's like opening the door. Holy smokes. This is a human. That's not just laying down flat and static. They're moving. Things change when we move, right? 2021 study, 87%. On upright MRI, we saw neural compression that we didn't see laying down. And finally, you did a great job on this one too, as far as the cost goes. The cost is just no longer an objection. It's 17 million kroners. That's the cost of 3 patients for long-term sickmelding for 1 year, right? Like, this changes the outcome. It changes the test. It changes the treatments. Faster recovery, reduced social costs. Yeah. Patients shouldn't have to travel. Norway, come on. I'm super proud. Jeg mottar dette på engelsk fordi det så komplekst, så jeg vil gjerne være nøyaktig, men jeg vil si at jeg så stolt over å bo i Norge. Jeg har fått norsk statsborgerskap, jeg har bunad, jeg har norsk... Jeg mener det, jeg har det. Veldig stolt. Men kom igjen, Norge, vi kan gjøre det bedre enn dette. It's not psychological, people. It's not. It's not in your head. It's mechanical. In our clinic, we do Atlas orthogonal protocol. So this is looking at the frontal, lateral, horizontal. We're looking 3-dimensionally at the upper neck. We're making calculations to see exactly how many degrees that green line is center, how many degrees the atlas has shifted. You can't see this. You can't feel this. You need to see it, right? To see is to know. Not to see is to guess. We take these pictures on very strict geometrical patterns that we do. We align up. It needs to be right. And this allows us to make the correction and to get it back to orthogonal, which is 90 degrees. That's our goal, 90 degrees, to correct the relationship with the head and the neck and gravity. That's our goal. You can see clearly a huge rotation. You can see laterality. We can see also 2.2 degrees of retrolisthesis on number 5. You can actually kind of see there too. I guess now that you guys are radiologists, you know better than this. Look at this. Do you see how the space is changing? Do you see how the body is starting to adapt to the changes? The body is so smart. It doesn't need any help. It just needs no interference. This is from a colleague in New Hampshire, before and after, 10-year-old boy. You can see the curves completely changed. Before and after upright MRI, 12 hours after the atlas orthogonal correction. Again, from Scott Rosa, my colleague, shout out to him. Before and after, back to 90 degrees. Before and after, that's our goal. Absolutely remarkable. And we're not even at the great, like, just wait a second, you're gonna see something that's absolutely out of this world. So how do we do it? What do we do? Well, after we take the three-dimensional images, we use this crazy looking machine to make the correction. We put in the degrees that we found from the pictures. This is physics. We're using about 3 kilos of force to make the correction. Most people, if you talk to somebody that's gone to me, you'll know that you don't even feel anything. It's like so light. It's like the amount of force it takes to press the doorbell. Ding dong. But when you have the right vector, when you have the right motvek, you can lift a car with one finger, but you need to have the right angle. And so I know the book is critical of chiropractors, and I got to say I agree with some of it, because I've seen some of these patients that have been just generally manipulated without looking at x-rays to see where it is and which way it is, and when to and when not to. Whew. I have some of these people, you see. So it makes me frustrated. We need to be better, chiropractors. We need to be better. So we're looking here at the angle, 3 kilos. Again, we're working on some research now showing that it only takes about 10 to 20% of the transmission to make a 3 millimeter correction. So very small forces when done at the right place at the right time. Now what I'm going to show you is exactly what's happening, okay? And this is absolutely fascinating. We're looking right there. Right there. This is a video fluoroscopy of the correction. This is the instrument. That's the atlas. This is the head. We're laying on our side, just like this. Watch. Boom. That's how we make the correction. So gentle. Let's watch it again, because I just love seeing that. It's cool. The friction coefficient of this joint is very small, meaning that it doesn't take much to make the adjustment, especially for the people that have hypermobility issues. You cannot let them go into rotation with high velocity, low amplitude manipulations. You need to make the correction neutral at the proper vector to avoid creating any more damage. What we're looking at here, and this is, we're getting to the finale here, so buckle up here. How am I doing on time? This is what's called the carotid sheath, probably one of the most important neuroanatomical structures in the body. It sits just in front of the atlas exiting the cranial vault. It houses some important things. It houses the jugular vein, which we talked about, the carotid artery, and some pretty important nerves. Maybe some of you have even heard of the vagus nerve. Yeah. So cool to see in the last year, like Torkil Faru, which we did an event with, and Christian Zahn talking about it, and vagus nerve in a new book. We've been talking about this stuff for 20 or 30 years, right? Like, welcome. The cranial nerve's super important. What happens is when we have the atlas misalignment, you're going to see that it gets compressed. On upright specifically. This is upright imaging, before and after. Scott Rosa, thank you. Look at the shape change before, after the correction. And to see it actually in motion, again, we're looking right at the side, cut in half right here. Oh, nothing there. Almost complete occlusion. And then opens up. You see the pulsation. What this means is headaches, dizziness, brain fog. And there's the vagus nerve sitting right in front of the atlas. Glossopharyngeal nerve also, we see people that have, I got gum pain, I got tooth pain, but the teeth are fine. Well, maybe the trigeminal nerve is involved, specifically the lower branch. We published earlier this year in the journal, I'm sorry, this is, okay, no more research, I promise. Maybe one more. We published this earlier this year in the Interdisciplinary Neurosurgery Journal. And this is a patient with whiplash injury, cerebral spinal flow issues, headaches, brain fog, cognitive issues. We showed how after we correct the atlas, we see changes in the CSF flow. So this is looking at a sine CSF image from the side. You see the black here, very weak, coming in and out, and you see how strong it is coming out. And a little bit of regurgitation, meaning going backwards. It's like we open it up, and of course, let the body do the healing. You can model these things, 4-dimensional MRIs, you can see it. This isn't, again, my theories. We're working on a study right now. It's under review. This is the preliminary results. We're finding that on average, 3 millimeters of misalignment is equal to something like 30 to 40% increased pressure of spinal vesca, spinal fluid. So it's big. Probably one of the most remarkable things I've ever seen. And this isn't because of Scott Rosa and how incredible he is, but it shows how incredible the body is and that the body can heal. That's what I want you to understand from this, okay? We're looking at a patient with MS. You see the lesion in the spinal cord and afterwards. And we're trying to figure out, why is this happening? Why is the body healing? I don't know. But what the research is starting to show is that, from Flanagan, he's showing this, that when we have these misalignments and the malformations and the issues in the upper neck, it's blocking this spinal vesca coming in and out of the cranial vault, leading to neurodegenerative issues. I want you to get this, that our goal is not to treat or cure anybody of anything. Our goal is to make the correction, allow the body and the geometry and the relationship with gravity to be as it should. Before and after MS patient with a lesion in the brain. Again, I'm not claiming to treat or cure anybody of MS. It's the body that does the curing. It's the body that does the healing. As long as you give the nutrients, as long as you move enough, and as long as we have no biomechanical obstruction, the body can heal. Seeing these things, there is hope. We don't have to learn to live with it. We can, now that we're finished, we can, wait a second. We're just getting to the finale here. We can think right, eat right, move right. If this is misaligned, everything is going to be reduced, okay? I want you to get that. We can't meditate our way out of a biomechanical issue. We need to make the correction. We need to keep the correction. And you know what? Sometimes that means that everything is great right away. And for other people with chronic issues, we need to make the correction, keep it there, and let the body heal. Sometimes it takes a year or two. Sometimes it takes a week or two. Got a boy with daily migraines, hadn't been to school for years. One correction, back on track, focus, back in school. It happens. And unfortunately, we have other people with real chronic issues, things like Eagle syndrome and hypermobility issues, chronic migraines that have got a bunch of Botox. And we got all these people, and those people sometimes take more time. But again, although I can't guarantee I'm going to treat and cure everything of everybody, what I can guarantee is when we make the alignment, when we make the correction, the body has a better chance to heal. And that's what we can ask for. Thank you so much.
Ja, tusen takk.